Hi, everyone. This is Michelle Loy. I'm the education coordinator for BloodNet, and I'm very pleased to welcome you all to the fourth webinar in our series called What's in the Bag? Pediatric Blood Transfusions, What We Have Learned and Considerations for Next Steps. So we're also proud to offer CME credit for this webinar. So in order to get CME credit, first you register at this site here and with the corresponding QR code. And then if you've already registered, then you can text VEKTAV to this number, or you can navigate to that website and then type in the code there. So the learning objectives for this webinar is to discuss commonly transfused blood products, to evaluate current data and new developments in blood processing and products in the US, and to discuss evidence-based clinical approaches to blood transfusion in pediatrics. And lastly, we will describe how we can evolve our understanding of the pediatric transfusions through the vein-to-vein PEDS or REDS for P database. So we have an excellent panel of speakers lined up for you today discussing this timely topic in the setting of blood supply scarcity. I would like to introduce the host of our program and moderator of the Q&A session, Dr. Marianne Nellis. She is an associate professor in the Division of Pediatric Critical Care at Cornell and also serves as the vice chair of the BloodNet Executive Committee. She has cultivated expertise in clinical and translational research with an involved interest in blood product utilization. And our first speaker is Dr. Cyril Jacquot from Children's National. He's a faculty member of both pediatrics as well as pathology, and he serves as medical director of their blood donor center. So welcome, Dr. Jacquot.
We'll talk about the potential adverse events that can happen from the additives, and also talk about bag plasticizer. That's sort of a topic that's gaining traction and has a lot of visibility right now, especially in Europe. Well, so first of all, in the bag, we have blood components, what we're actually using to treat the patient. And I have images here of the four main blood components that we transfuse. So in the upper left, we have red blood cells. These, of course, provide oxygen carrying capacity through hemoglobin, as well as increasing sort of red blood cell mass that can be helpful as well if a patient has bleeding. In the upper right, plasma provides coagulation factors. In the bottom left, we have platelets. These are often used prophylactically for low platelet counts in patients, for example, undergoing chemotherapy, but it can also be used for hemostatic purposes during surgery. And in the bottom right, we have cryoprecipitate. This is derived from plasma. It's a smaller volume than plasma, but the important thing to note about cryoprecipitate is it only contains certain of the factors which is in plasma. So cryoprecipitate is specifically enriched in fibrinogen, fibronectin, factor VIII, von Willebrand factor, and factor 13. Now, throughout the world, there are quite a few different storage solutions, and most of these are known by their acronyms from ingredients, and I'll present in the next few slides what's involved in each of these. So we have names such as CP2D, CPDA, additive solution, AS1, 3, and 5, and then outside of the US and Europe, there's SAGM. Now, there's mixtures of various ingredients in these solutions. Some of the typical components are dextrose. Of course, that's a nutrient for red blood cells. Citrate, because it binds to calcium, is an anticoagulant. Some of the solutions contain adenine, which helps to maintain red blood cell adenosine triphosphate, which prolongs their stability, storage, and storage. Mannitol, through its osmotic property, can help stabilize red blood cell membranes. And there are usually buffering solutions to help maintain the pH in a narrow range to prevent any acidotic or alkaline damage. And then electrolytes to sort of mimic what's in plasma. So essentially, these solutions are kind of created to approximate the plasma so that the cells can be stored for a certain amount of time. And the advantage of that is, of course, if we want to maintain an inventory of cells, we need to be able to store them for hopefully several weeks at a time. For red blood cells, the FDA has determined shelf lives. These are based on hemolysis analysis, as well as recovery studies that were done previously with chromium labeled red blood cells. So for CPD and CP2D, we can keep those cells for up to 21 days. CPDA with the adenine extends to 35 days. And then the additive solutions, which are primarily what is used, is up to 42 days. The longest storage time in clinical use is up to 49 days. That's for certain cells stored in SHGM in Germany. Platelets, unfortunately, have a shorter shelf life. That's because they're stored at room temperature, which increases the risk of bacterial contamination. And there recently in the United States was FDA guidance that changed sort of the framework for culturing bacteria from platelets. Currently, platelets can be stored from 5 to 7 days. That depends on sort of the testing pathway that's chosen or whether pathogen reduction has been applied. And Dr. Mo will talk a little bit more about that after me. Plasma and cryoprecipitate can be frozen for up to a year. These are acellular products, and so that's why there's a longer storage time. So this table here shows some of the anticoagulant solutions that are used to store whole blood. And whole blood can then be divided into plasma and red blood cells. And the red blood cells can either be stored within these anticoagulants, or they can have additives which prolong the shelf life. If red blood cells are stored in these three solutions, the hematocrit is usually about 80%. And CPD, CP2D, and CPDA, you can see they all contain citrate, again, as the anticoagulant, dextrose as a source of energy, and a buffer solution. CPDA, in addition, has adenine, which is why it allows for a longer shelf life of 35 days compared to 21 days. And then these are selected examples of additive solutions used worldwide. And just going down the list here, so we've got, again, electrolytes, we've got various buffer solution. Now, citric acid and citrate, you can see, is only contained in AS3 and MAP, but these solutions, of course, are added to CPD or CP2D. And so the citrate actually comes from the sort of anticoagulant that's the base solution. Then we add adenine, dextrose, and mannitol. Again, those are to sort of stabilize red blood cells and to provide them with a source of energy. You can see that the pH is usually in a sort of a narrow, slightly acidic range. And then these additive solutions are paired with different anticoagulants. The first three on the left are the ones in use in the United States. They are FDA approved. Whereas SAGM is the primary European formulation, and then MAP is used in Japan. For platelets, we also have sort of an additive solution. This is a more recent development, but one of the advantages, or some of the advantages of the platelet additive solution is, first of all, platelets, when they're collected either through apheresis or from whole blood, they are stored in plasma. So you can actually substitute the plasma out for these platelet additive solutions. That allows you to have the plasma available for a different patient if you want. The advantages of removing the plasma are that you have a lower risk of allergic transfusion reactions, and also a lower risk of hemolysis that can be due to isohemagglutinins. So for example, if a patient is group A, but they get platelets from a group O donor, some of the anti-A in the donor's plasma could cause hemolysis of the recipient's red blood cells. Platelet additive solutions, they have a slightly different ingredient list, but they do contain electrolytes, again, citrate, and then acetate phosphate as sort of a buffer. And then PAS1 does contain some mannitol to help stabilize the cellular membrane. So what are the adverse events that can happen from the storage solutions? And here I'm really focusing on sort of these metabolic blood storage complications. Of course, you can have transfusion reactions, you can have infectious, non-infectious complications of blood transfusions, but really here I'm talking about the effect the additive solutions have. And these are all related to the metabolites that are included and how quickly they can be processed by the recipient's body. So red blood cells, of course, contain potassium. So if there is any damage to red blood cells, you can have increased potassium release. Citrate, because it binds to calcium, can cause complications in the recipient. This usually manifests as sort of tingling due to nerve effects. There can be hypotension. There can be muscle cramping because of the citrate chelating the calcium. And so patients who receive a lot of blood products at once may benefit from calcium supplementation. There can, of course, be acid-base disturbances, changes to pH. Hemoglobin does depend on 2,3-diphosphoglyceric acid, 2,3-DPG, to sort of mediate its affinity for oxygen. So as the 2,3-DPG goes down, hemoglobin actually holds on tighter to oxygen, which means that if a tissue is hypoxic, its level of hypoxicity needs to decrease more for the oxygen to be released from hemoglobin. Because there's dextrose, that can be a risk for patients with diabetes. And of course, red blood cells are refrigerated. And so a high volume of red blood cell transfusions will decrease the temperature, the body temperature, which contribute to coagulopathy. And so again, for high volume, it's recommended to use blood warmers. Now, in particular, smaller patients, we worry most about these metabolic complications. And there have been concerns about free adenine and mannitol causing osmotic problems for neonates. And for that reason, historically, AS3 was favored because among the additive solutions, it's the only one that does not contain mannitol. Since then, many studies have demonstrated that for small volume transfusions, these additives are safe, including for neonates. And there is anecdotal evidence in small observational studies that suggest that additive solutions can be used for large volume transfusions as well, but you do have to monitor the patient. And one of these abstracts below here compared CPDA and additive solution transfusions for infants on ECMO and did not find any difference between the two patient populations. The other thing that has gained attention is this storage lesion. So of course, these solutions try to approximate plasma, but certainly a red blood cell that's stored in a bag in a refrigerator is going to undergo changes compared to the one that's in the body at body temperature in plasma. So the changes that happen over time are a decrease in the 2,3-DPG, which again causes hemoglobin to hold on to oxygen more tightly. You see acidotic progression over time and release of free hemoglobin. In addition, there's increase in potassium. And so both the free hemoglobin and potassium are due to essentially leakage outside of the red blood cell due to membrane changes over time, as well as an increase in lactate as the cells transfer more to an anaerobic respiration. And these changes have, again, garnered a lot of attention, and there has been concern that older stored red blood cells could potentially be harmful to the recipient. A number of studies randomized patients to either get standard issue versus fresh blood. And I've listed here a few of those studies. So some were done in premature infants, some were done in critically ill adults, some were done in cardiovascular cases, and some were done in Africa. And the common theme from all of these is that there was no difference noted between the patients who received sort of standard issue, which included some older units, versus fresh. Now, each study was slightly different. In some cases, it was less than 7 days, some cases less than 10 days. So there were some slight differences between kind of how the groups were defined. But again, there was no difference detected. And meta-analyses have confirmed that there was no influence of red blood cell age on mortality or morbidity. Most of the studies were done in adults, so the quality of evidence for neonates and children is low. Similar studies have not been performed for platelets. The issue with platelets, of course, is that they're only stored for 5 to 7 days. So it would be very difficult to find a meaningful difference, I would think, between platelets at 3 or 4 days of age versus 6 or 7. And I started by talking about component therapy, but I also would like to include whole blood in the discussion. The advantage of component therapy is, of course, you address the patient's specific needs, be it low platelet count or anemia. But a patient who has traumatic hemorrhage may benefit from whole blood, where you provide all the components at once because that is what the patient is losing. One of the advantages of whole blood compared to component therapy is that because the whole blood is comes in its original anticoagulant solution without additives, the content of sort of the non-blood components is higher in the component therapy versus the whole blood. And this is a table from Dr. Spinella's paper comparing a component on the left side. So you have a red blood cell and FFP and platelets. And you can see that the volume is slightly higher than the single whole blood unit, but you can see that the additives are almost 3 times as much as in the single whole blood. And as a result, the components are more dilute compared to the whole blood unit. And so the advantage of the whole blood there is that you really get sort of a more concentrated, packed blood product. In addition, it's a single bag, which makes it easier to transfuse than potentially hanging 3 different bags at once. The difficulties of whole blood are, there are some concerns about hemolysis because there is no universal donor whole blood. So, whereas for Group O red blood cells, we say that's universal donor, Group O whole blood is going to contain Group O plasma, which has anti-A, anti-B. And so if you wanted to transfuse someone who's type A, really the blood for them would be Group A whole blood. But you can imagine the difficulty of storing Group A, Group B, Group AB whole blood. And so one way to approach this has been to use what is called low titer Group O whole blood, which is essentially blood from donors who are known to have a low anti-A, anti-B titer, which means that even though the plasma is technically incompatible for a non-Group O recipient, the amount of antibodies are low enough that the risk of hemolysis is low. And there are some logistic constraints that come with whole blood. Of course, you have to have an agreement with the blood supplier, and then you have to decide what happens to the whole blood if it's not used during the time frame, so that you don't waste the blood product, especially nowadays with the shortages we're having. And lastly, I'll talk about the bag. So we've talked about everything that's in the bag, but the bag itself contains some chemicals. So for red blood cells, the main composition of the bag is polyvinyl chloride with a plasticizer called DEHP, which has some nice advantages in that it protects red blood cells from hemolysis during storage. The problem is it has some similarities to endocrine or hormones, and it does have some possible toxicity associated with it, including infertility, obesity, and diabetes. And actually, recently, the European Union, over time, they've actually reduced the use of DEHP, but there was sort of a carve out for medical devices, but that also seems to be going away in the next few years. So there is a sort of a feverish search for an option that is non-DEHP, and many companies are looking into alternatives that they can hopefully validate and start using in blood products as DEHP is sunset. Platelets are actually stored in slightly different bags, which I don't think have as much concern at this point. Platelets need sort of this high gas permeability in order to maintain their activity, and that's something that red blood cells don't. So to summarize, we've discussed additives and anticoagulants. These are needed to store the blood products until transfusion is indicated. And the composition varies around the world, but generally they rely on sort of the same types of ingredients to sort of maintain a favorable environment for the blood components. These are all well tolerated for routine transfusions, but there can be some concern with high volume transfusions, especially in small children who may not be able to metabolize these well. The additives in the component therapy can cause dilutions compared to whole blood, so that may be a reason to use whole blood for traumatic hemorrhage cases. Plasticizers, which are used in blood bank, have been linked to adverse events, and efforts are currently underway to find alternatives. And I think we'll hold questions till the end unless there's a quick one right now. So thank you very much for your attention.
Thank you so much, Dr. Jecko. Are there any just quick clarifying questions? If not, we're going to hold the major questions till the end. Okay, great. We're going to move on to our next speaker. Dr. Dolores Moe is also an assistant professor of pathology and pediatrics at Children's National. She's the director of the coagulation laboratory and the associate director of transfusion medicine. Today, she's going to be speaking to us about what is done to the bag. And Dr. Moe, the floor is yours.
Great. Thank you very much to the speakers for the invitation to speak. Oh, let me make sure I get started here. So picking up where we left off, so I'm going to talk a little bit about how we collect blood products and process them. And then from there, we'll move on to kind of discussing some of the modifications that we can perform to the products, either at the point of manufacturing, during the manufacturing process, or after the products are distributed to a transfusion surface. So to go over the outline, we'll start with just an overview of blood product collection techniques, sort of the major ways that we collect products in the US, and then the types of modifications that can be performed. And specifically, we'll be talking about leukoreduction, irradiation, plasma reduction, and pathogen inactivation. So blood collection really takes on one of two flavors. So the one that we primarily perform at our personal hospital donor center here at Children's National is that we perform whole blood collection. And this is basically where we just have our donors come in and collect whole blood and either process those into additional components or potentially distribute as whole blood. Although our particular donor center manufactures them into components. So these products are typically anywhere from 450 to 500 mLs in volume. And as Dr. Jacot covered earlier in his talk, we have a variety of different available additive solutions and anticoagulants available. And basically what I'm showing here is just a picture of our mixer that actually calculates the amount of volume that's collected and also serves as a scale at the same time in order to ensure appropriate collection volumes. Just to give a quick overview of the different component manufacturing methods. So the first two on the left are the ones that we primarily do in the US. The Buffy coat method is not approved here in the United States. And basically each donor center decides what types of products they want to manufacture from each of their collections. So the two main methods that are used are the platelet-rich plasma on the left, and as well as whole blood filtration. So if you're using the method on the left, you primarily create red blood cells, a single whole blood derived platelet unit, as well as plasma. If you're using the method in the center, basically you are just removing the platelets. You're not going to manufacture platelets from this product, and you just end up with red blood cells and plasma. And then in the Buffy coat method, which again is not available here in the United States, you actually can create pooled platelet products in addition to red blood cells and plasma. So just to go into a little bit more detail for the method that is frequently used here in the US, we'll go through step by step through the platelet-rich plasma method. So we have our donor who comes in to donate. And so we get our whole blood here in our main collection bag. And from there, we want to perform a centrifugation step that then separates out the red cells, which are heaviest and tend to fall to the bottom when you centrifuge, as well as our platelet-rich plasma. So this is what we call a soft spin, where we separate just the platelets and plasma from the red cells. And then from there, we can actually separate out the platelet-rich plasma from the red cells remaining and centrifuge again. So at this point, this will separate our platelets from the plasma remaining. And then again, you remove the plasma. And so you end up with three different products. So your packed red cells, your platelet, and then your plasma. So this is all from one single whole blood donation. In contrast, for apheresis blood collection, you can actually collect particular components at the time that the donor is there. So you draw whole blood, you have an instrument. This happens to be the one that we have in our donor center. It's called the Trima XL. And basically it has a built-in centrifuge that then separates all the components by specific gravity. And depending on what type of component you would like to collect, you program the machine accordingly. So our particular instrument can collect platelets, and those could be single, double, or triple units, as well as red cells and plasma. And the difference with the whole blood is that whatever components are not being collected at the time are actually returned back to the donor. And so this actually allows for donors to donate more frequently because we're not taking necessarily 450 to 500 mLs of whole blood out at any given time. And so they can actually donate much more frequently. So for a platelet donor, they can actually come essentially every 2 weeks, as opposed to having to wait the full 8 weeks in between donations for whole blood donors. And then as Dr. Jacot mentioned in his talk, platelets do come in 2 flavors. So as we saw earlier, if you want to create platelets from whole blood, you can by combining, by separating them out. And then to make a full adult dose, you then take platelet concentrates from 4 to 6 different donors and combine them together to make 1 adult dose. Now, of course, we're a pediatric hospital. And so we tend to look at things more at single units, even though we have 100% apheresis platelets here. So in contrast, you can also just collect platelets like we saw with the other apheresis collections. And for these, all the platelets come from a single donor. So we don't pool any other donors. They're all originating from 1 person. And the amount of platelets you collect with apheresis is equivalent to what you would get if you pooled 4 to 6 of those whole blood derived units. And as I mentioned, and Dr. Jacot mentioned earlier, cryoprecipitate can then be manufactured from fresh frozen plasma. Again, not something that we necessarily do here at our donor processing center, but are done at larger blood suppliers. So moving on from collections, the first modification I'm going to talk about is leukoreduction. And really we're going in this order because this is something that happens the majority of the time at the manufacturing facility, not at the transfusion area. So leukoreduction is simply a term for using a filter to remove white blood cells from blood products. And of course, the AABB has very specific standards about the degree to which we have to perform leukoreduction. So in order to call a product leukocytes reduced, it has to have less than 5 × 10⁶ residual leukocytes in 95% of the units that are sampled. And here in North America, essentially almost all blood products are leukoreduced. There are a small number of centers that may be producing non-leukoreduced red cells, but those are really the minority. And you can see that the standards here, less than 5 × 10⁶ leukocytes, that is actually relatively high. So compared to international standards, in Europe, they typically require a residual leukocyte number of 1 × 10⁶. So that's 5 times less. And for apheresis products, because of the way that we collect the products with the automated instruments, the leukoreduction capabilities are essentially built in, although there are exceptions where sometimes it doesn't work. But for the most part, apheresis leukoreduction happens at the time of collection. Whereas with whole blood derived products, it happens essentially after collection. And just a reminder, for certain blood products where we want to keep the leukocytes in the bag itself, like granulocytes and hematopoietic progenitor cells, you should never ever leukoreduce those because essentially there's no point in giving a product if you've leukoreduced those. So just a quick overview, going back to our earlier diagram with a blood collection, the fact that pre-storage leukoreduction can happen at a number of different steps within the collection process. So if you're collecting whole blood, using that whole blood filtration step where you're not collecting any platelets, you would just simply have a whole blood filter that is connected to the collection bag. And this filter actually filters out platelets as well. And that's why we can't necessarily collect platelets using this method unless you happen to have a set that spares the platelets. So from there, you would prepare leukoreduced red cells and also plasma. Now, if you're using the platelet-rich plasma method, you can have separate filters. So this is the one for the platelet, and this is the one for the red cell. So after you collect your whole blood into the bag, you have different centrifugation steps, and the filters work at those steps to eliminate the leukocytes. So you end up with both leukocytes reduced red cells as well as platelets. And again, the 5 × 10⁶ is essentially the cutoff. But with the current generation of leukocyte filters, you usually end up with much lower numbers of leukocytes compared to what is required by the standards. And sometimes leukoreduction does fail, and really the majority of the times this occurs because we have donors who happen to have sickle cell trait. They may not actually be aware they have sickle cell trait, and those sickle cells tend to get trapped in the filter. So about 50% of red cells from those sickle cell trait donors end up failing leukoreduction. And that's why we still have to have some quality control and test the units to ensure that the sufficient number of units are passing, that are fulfilling that standard. And it used to be before the majority of units were undergoing pre-storage leukoreduction, meaning essentially at the manufacturing facility, that we would actually advise that products all be transfused with a bedside filtration that would remove the leukocytes at the time that the unit was being transfused. So why do we do leukoreduction? So there are really three main reasons. So one is that white cells are a source of CMV. So, cytomegalovirus is very common in our population. Upwards of 50% of the population has already been exposed. And in somebody who has an intact immune system, it's not usually a problematic infection. However, if it's a congenital infection or if it occurs in immunodeficient patients, then they could be life-threatening or even fatal. And many times the patients that we are transfusing have those particular conditions. So this is one of the major reasons to leukoreduce. Another is that leukocytes express HLA antigens, both class 1 and class 2, on the surface. And so if we remove the leukocytes, then we decrease the risk of patients becoming sensitized to HLA antigens that are foreign to their immune system. And for those of us who work closely with patients who are frequently transfused, like oncology and bone marrow transplant patients, we know that they often develop platelet refractoriness as a result of having HLA antibodies. And so again, this is something we want to avoid whenever possible. And then the last reason is that white cells can produce cytokines, especially as they're sitting in that bag during storage, and that can result in febrile non-hemolytic transfusion reactions. And that is actually one of the advantages that we have seen with moving from bedside to pre-storage leukoreduction, is that, with the bedside filtration, you still have the white cells sitting in the bag for a while, producing those cytokines before they were filtered out at the time of transfusion. Well, if you remove the white cells much closer to the time immediately after collection, then they don't have that chance to sit in that bag and produce cytokines and other materials. And even though leukoreduction filters these days are highly efficient, they still leave enough leukocytes behind that you could develop transfusion-associated graft versus host disease, which we'll talk about in an upcoming section. So for that reason, leukoreduction alone is not effective in preventing transfusion-associated graft versus host disease. Okay, and just a little bit more about CMV. So we talked about why it's concerning for patients with congenital immune deficiencies to receive, to be exposed to CMV. And so there have been a couple different strategies for avoiding CMV transmission. So one is that you collect only from donors who you know to be CMV seronegative. So that means that you test your donors and you determine whether they've been exposed to CMV. And as we mentioned earlier, the population prevalence can be as high as 50% for people who've been exposed. So that really cuts down on your donor population if you're only wanting to collect from donors who happen to be CMV seronegative. The other problem with CMV seronegativity is that you may be catching a donor who's actually in the early stages of infection. So they might actually have virions circulating in their blood, but they haven't developed antigens yet, and they're still in that window period, as we can see here. So basically, if they're early enough, we can't even detect it by nucleic acid testing, and we certainly can't detect it by serology. So if they happen to donate at this time, they're going to be CMV seronegative, and we think that it's a safe unit, but they could have circulating virions. And so for that reason, we use leukoreduction to try to remove as many white cells as possible. But like I mentioned earlier, it is not completely effective. So no single one of these methods is going to be 100% effective in preventing CMV transmission. And so what with the current generation of leukoreduction filters, essentially the risk is considered equivalent for the two. So in 2016, Megan Delaney and colleagues essentially did a retrospective observational pilot study looking at patients who had received leukocyte reduced only units and comparing it to a cohort at Emory that Dr. Josephson looked at, where the strategy there was to combine CMV negative donors whose products were then subsequently leukoreduced. And so the numbers are very small, as you can see, but basically of the 20 that received leukocyte reduced only, there were 8 patients who received 43 transfusions, and essentially none of them developed CMV infection following that as a result of the transfusion. Now, some of them did seroconverge, but actually breast milk is one of the major venues for transmitting CMV from parents to children, from the mother to the baby. And so we saw in most cases that both of these strategies are essentially equivalent in efficacy. So the next modification we'll talk about is irradiation. And so in the United States, that means that we are treating cellular blood products with either gamma or X-ray irradiation. And when we talk about cellular blood products specifically, we're talking about red blood cells, platelets, and granulocytes. And our AABB standard is that we treat these blood products with a minimum of 25 grays of irradiation to the central portion of the container and a minimum of 15 grays to all other parts. Now, these are by no means universal standards. So elsewhere outside of the US, in Europe and in Japan, they tend to have higher minimum doses. In some cases, 25 is the minimum dose for any part of the container. And what irradiation does is that it causes cross-linking of the DNA, which prevents donor T cell lymphocytes from engrafting and proliferating in transfusion recipients. And this is the effective way of preventing transfusion-associated graft versus host disease, which is a rare complication of blood transfusion, but essentially has no effective treatment and an extremely high mortality rate, upwards of 90%. So really transfusion or prevention is key here. Now, for products that have been pathogen reduced, we'll talk about that a little bit later, and products that have been previously frozen at some point in their storage life, you do not actually need to perform irradiation. And of course, if you're transfusing HPCs, you do not want to irradiate these. Excuse me, that's a typo there, and that's because they would essentially be ineffective if you then transfuse them. So what kinds of patients are at risk for transfusion-associated graft versus host disease? As you can see, many of the same patients who were kind of at risk for serious CMV infections earlier. So with suspected congenital immunodeficiency disorders, those undergoing stem cell transplants, and those receiving blood components from blood-related donors. And that's because those products could potentially be partially HLA matched. So how is that? So basically what happens is that if you have an immune system that is not able to defend yourself against these donor lymphocytes, you essentially cannot mount a response. However, we have seen quite a few case studies of patients who have intact immune responses and still develop transfusion-associated graft versus host disease. So how does that happen? Essentially what happens there is that if you have a partially HLA matched donor, so here's an example of a donor who's a parent and a recipient who's a child. And as you can see, clearly the child got one of their alleles from the parent, the HLA-A3, and the other from the other parent. So here we have what's called a unidirectional mismatch. So the concern here is that the child has both HLA-A2 and A3, whereas the parent is homozygous and only has A3. So when this donor lymphocyte is transfused into the child, it views the HLA-A2 as a foreign antigen and activates the basically destructive mechanism. However, with the recipient responding to the donor, you can see that because the recipient has A3 and the donor happens to be homozygous for A3, they view this as self, and so they have a tolerance for it. So it's basically unidirectional. So you have the donor T lymphocytes engrafting and then proliferating. And so for that reason, when you have donations that are from blood-related donors, you always want to irradiate them. And so, of course, irradiation is very important in prevention of transfusion versus associated graft versus host disease, but there are also significant risks associated with irradiation. And primarily that the cellular membrane can become damaged and result in red cells leaking potassium during the immediate the immediate post-irradiation period, as well as throughout the remainder of the shelf life. And because of this, we do shorten the shelf life of a red cell or after irradiation from 28 days from the date of irradiation. But as you can see here, this study was done in Australia looking at SAGM units that were exposed to radiation, and the potassium levels can really increase quite dramatically, especially in that first 24 hours. So you can see that here's a control product that has not been irradiated. Here's a similar one of similar age that has been. You can see the potassium levels are essentially double. And so for that reason, we want to irradiate these units as close to the time of issue as possible. But this isn't always possible. Not every transfusion service necessarily has an irradiator on site. And so they have to rely on the irradiation being performed by the blood supplier. The next modification we're going to talk about is plasma reduction techniques. And I've basically just lumped washing and volume reduction into this category. So washing involves essentially removal of pretty much all of the plasma from cellular blood products and then resuspends them in saline. And so the main reason for doing this is to prevent hyperkalemia. And we mentioned about potassium leaking into the extracellular fluid. This is to remove that extracellular fluid. It can also be used to prevent severe recurrent allergic reactions against again, proteins causing allergic reactions tend to be in the plasma portion. And so removing that helps decrease the chance of having those reactions, as well as removing any antibodies that may be present. So these could be incompatible antibodies, or potentially if you have exposure to T antigens, removal of those antibodies as well. And then similarly, so volume reduction is basically centrifugation and removal of the majority of plasma, but not all of it from cellular blood products. And this is to prevent volume overload. So we have patients who are very sensitive to volume and need a more concentrated dose of cellular blood products. Can also be used to remove incompatible antibodies such as ABO isohemagglutinins, and then prevent severe or recurrent allergic reactions. So in general, washing, it can be done with, it's primarily referring to red cells, so that you perform washing on those, whereas volume reduction is more commonly done to platelets, although you can wash platelets as well. And there are significant drawbacks to performing plasma reduction, especially washing. So for washing, you need dedicated equipment. Here in the US, we tend to do automated washing with this particular instrument called the COPE 2991, which, if you don't do it very frequently, results in challenges in finding, the appropriate techs who are trained and competent to perform the washing and maintaining the appropriate equipment. All these processes take time and delay issue of blood products from the blood bank. And as I mentioned earlier, washing really can reduce your yield. So up to 15% of red cells can be lost and 33% of platelets. Platelets also don't like to be agitated, and so you tend to end up having premature platelet activation, which makes them less effective in vivo. And red cells can undergo shear stress and have hemolysis and increased potassium leakage. So on the one hand, you may be performing washing to remove some of that extracellular potassium, but that same process can actually cause even further leakage. And so for wash products, typically, if they're done in an open system, meaning that you breach the sterile barrier of the blood products, it really shortens their expiration. So for red cells, it goes to 24 hours. And if you're doing platelets in an open system, it shortens their shelf life to 4 hours. So these days, with additional products on the market that Dr. Jacot alluded to, including platelet additive solution, where you essentially remove up to 33% of the plasma in a platelet unit, or even pathogen reduced products where, again, you have less of that native plasma available, there are better alternatives to performing washing and volume reduction. And again, washing can remove some leukocytes, but it, again, is not effective in preventing transfusion-associated graft versus host disease. And then the last area I'm going to focus on is pathogen inactivation or reduction technologies. So there are three main platforms that we're going to talk about. The one that is approved in the US is called the Intercept system. And it is approved for platelets and plasma and essentially uses amotosine, which is a type of sorlin, a compound that can actually intercalate within DNA when it's activated by UV light. There's another platform available called Mirasol, and this is in Europe and the Middle East. It is actually currently undergoing a phase 3 clinical trial here in the US, but has not been approved. And this is applicable to platelets, plasma, and whole blood. And rather than using amotosine, which has some concerns because sorlins are activated by UV light, there's concern that there could be interaction with therapy devices that are used for neonates with hyperbilirubinemia. Although most of the devices available in the US don't have wavelengths that would interfere with this, but there are concerns for cutaneous reactions, rashes that can occur this way. In contrast, riboflavin is a naturally occurring vitamin, it's vitamin B2, and so there's less concern when there's residual riboflavin left behind. Similarly to the Intercept system, Mirasol also uses ultraviolet light to activate the riboflavin and then from there inactivate the DNA in pathogens. And then lastly, the system that is primarily used in Europe right now is called Theraflex. It has two different essentially mechanisms depending on which product. So for plasma, it involves addition of methylene blue as in pill form to the plasma that then causes inactivation. And then for platelets, it's actually direct exposure to UVC light. So there's no photoactivation complex here, just direct exposure to light and then vigorous agitation to cause inactivation. So just a little bit more of a focus on Intercept because it is the one that is FDA approved. This was approved in 2014. As we mentioned earlier, the amotosine intercalates into regions of the DNA and RNA of the nucleic acids and then cross-links when you expose it to UV light and prevents it from replicating. So for the same principle that is applied towards pathogens, it also does the same thing for residual leukocytes. And so for that reason, for the products that are pathogen reduced, you do not also need to irradiate them. So we still are lacking a lot of in-depth data about the use of pathogen reduced products in pediatric populations. I talked about some of the concerns earlier. My colleagues performed a nice review of the literature in 2018, just kind of looking at the studies that actually included pediatric data. There weren't a whole lot, but for the most part, many of these have similar rates of acute transfusion reactions, no concern for increased adverse events or bleeding. And at Yale, they switched over to almost 100% pathogen reduced inventory. And what they saw was, again, no significant concerns from a safety perspective, but they did see increased numbers of transfusion as a result of using the pathogen reduced platelets. And that's because with the processes that go into pathogen inactivation, you tend to get much lower counts, post-transfusion increment counts for platelet transfusions. And although that has not translated into increased bleeding events. And so the pros of pathogen inactivation obviously are that you reduce your risk of transfusion transmitted infections, and you protect against pathogens that we may not currently test for or are emerging. And as Dr. Jacot mentioned, the FDA also had a recent guidance about bacterial mitigation strategies in platelets, and this satisfies one of the single-step strategies. Again, several cons. Many of these platforms are only approved for certain types of blood products, so we have to continue to use other modifications to satisfy those, including for red cells, which are very commonly transfused. There have been concerns about risk of adverse events, specifically respiratory distress syndrome, and actually the FDA labeling for the Intercept system includes a warning about that. And as I talked about earlier, there is a decreased platelet yield because of the requirements for manufacturing are more stringent. The blood centers cannot produce as many, translating to higher costs for each of these units. And because these units tend to result in a lower transfusion increment, the clinicians tend to order more products and patients get exposed to more donors as a result. There are also concerns that there might be increased HLA sensitization as a result of some of the manipulation that goes into producing these products, although there's sort of conflicting data on that at the moment. So here's just a summary of the various bacterial mitigation strategies that are available right now, and pathogen reduction happens to be the one that satisfies that one of those single step strategies. So here's the summary of all the modifications we've talked about. As you can see, not all of them are available for certain products. And then for certain patient populations, some of these modifications are obviously more important than others. So to summarize, we talked about various modifications that blood products can undergo, either during manufacturing or after they're issued to the transfusion service. And really the risks and benefits of performing these modifications should be weighed against their availability, the time and labor that are required to perform them, and the fact that we have new technologies coming out and novel products that may actually lead to changes in the way that we employ these modification strategies. So with that, I'm happy to take any quick questions, although it sounds like we're saving the major questions for the end.
There is one clarification question, Dr. Mo,
Sure.
if you don't mind, if you could explain again why the blood from patients with sickle cell trait would fail leukoreduction.
Sure. Yeah. So because of the way that the sickle cells are deformed, they can get stuck in those filters. And so that prevents the leukocytes from being appropriately filtered through. So they end up, the filter gets clogged, and so the leukocytes can actually get through into the final product.
Okay, thank you very much. If there are any other quick clarifying questions, we can take those. Otherwise, we're going to save the big questions for the end for panel discussion. Okay, great. Thank you so much, Dr. Mo. I have now the privilege to introduce Dr. Stacy Valentine, who is joining us in the name of pediatrics from nearby Disney World, I think. So thank you for taking a break from your vacation to join us. Dr. Valentine is an associate professor of pediatrics and works in pediatric critical care medicine at the University of Massachusetts. She led a 5-year process of developing red blood cell guidelines for critically ill children, which she will discuss with us today. Thank you so much, Dr. Valentine, for joining us.
I always do that. Thank you so much, Marianne. Thank you. It's a privilege to be able to be here today to talk to you and to follow these amazing talks. So thank you very much. And I will be talking about the Transfusion Anemia Expertise Initiative. And let me see, there we go. So during this objectives, first I just want to give you a brief history of transfusion practices in the PICU and kind of what led up to TAXI. I will then talk about the clinical recommendations for transfusion practices in the PICU, which is called the Transfusion and Anemia Expertise Initiative, as Marianne had mentioned, and then also to apply these methods to reduce unnecessary blood transfusions. So as we all know here, blood is a precious resource. Red blood cell transfusions can absolutely be life-saving when we need them, but they can also cause significant harm, and the risks, benefits, and alternatives of transfusion must be carefully weighed with each transfusion and every time. So just to give a brief history of where this had began, of course, we all know Paul Iber's study back in 1999 that really looked at transfusion thresholds in critically ill patients, or called the TRIC trial. And it was really the first time that they were looking at a restrictive, so hemoglobin of 7 versus greater than 9 in over 800 adults. And what they found is that restrictive strategy was not inferior to a liberal strategy. So really kind of changing shifting our understanding of complications and being able to lower that transfusion thresholds. And just to kind of see where we were in terms of pediatric Jacques Lacroix's group conducted a survey on transfusion practices amongst pediatric intensivists. And here you can look at that the hemoglobin level for transfusion was really kind of all over the map in terms of anywhere from less than 7 to less than 13. And they looked at for those 4 case scenarios of bronchiolitis, septic shock, trauma, and cyanotic cardiopathy. A little bit later than that, Scott Bateman and Jacques and colleagues with the Pediatric Acute Lung Injury and Sepsis Investigators Network, which then became where BloodNet is born, conducted the anemia, blood loss, and blood transfusion in North American children, and really looked at a prospective observational multi-center study across the US and Canada, characterizing anemia and blood loss in children, looking at almost 1,000 children. And remarkably, 49% had received a blood transfusion, and the mean pre-transfusion hemoglobin was 9.7. 33% of those were anemic on admission, and then 41% developed anemia. What was most pronounced is that in quite a few patients, so in 42% of those patients, it was hemoglobin alone that was the trigger for transfusion, and that hemoglobin was 8.2. Looking at this, phlebotomy contributed significantly to blood loss and then subsequently to anemia. And as you remember, an additional 41% of those patients became anemic during their ICU stay. And looking at this, transfusion in the PICU is associated with worse outcomes, and really starting to think about how we can adequately restrict our resource and to use it appropriately for those patients who need it. So of course, we all know Jacques Lacroix's landmark study, the TRI-PICU study, which followed Paul Hebert's TRIC trial and looked at the liberal transfusion threshold group versus a restrictive group. And so that restrictive group had that transfusion threshold was less than 7 versus less than 9.5. All of these pre-storage leukocyte reduced, so different than Paul Hebert's, which was only half of that, and looked at, and I think one of the most important things to think about when you start to extrapolate this, and then subsequently when we talk about TAXI, is who were these patients who were involved in the study. And so stabilized patients, what it means is a mean arterial pressure not less than 2 standard deviations below normal for age, and cardiovascular support that was not increased for at least 2 hours. And so important to keep those in mind as we start to extrapolate the TAXI guidelines. So what they found is that the restricted transfusion strategy was not inferior to a liberal transfusion strategy. There was no new or progressive multi-organ dysfunction. There was no increased risk of MODS. And there were 44% fewer transfusions. And these findings similarly were seen in the subgroups, so the cardiac subgroup, surgical subgroup, and sepsis subgroup as well. So looking at transfusion thresholds over time, we certainly have decreased over time. These were studies earlier in 2006 to 2010, continuing to decrease. So averages, our mean is 7.5, but you can see that there are still quite a few transfusions that are occurring, even using the criteria that was described in Jacques' study, over 7. So what can we do to reduce unnecessary transfusions while preserving this critical resource for those that need blood? I like to think about patient blood management, and specifically pediatrics or pediatricians, pediatric patient blood management. And I put up 2 definitions here from both the Society for the Advancement of Blood Management as well as the AABB, and really thinking about using evidence-based medical decisions, really thinking about transfusion decision-making and how we can use that evidence to be able to give transfusions to those who need it and minimize blood loss and optimize the red cell mass of those patients. So thinking about that, I think about, when I think about patient blood management, I think about transfusion thresholds, anemia management, blood conservation, hemostasis management. And today we're going to talk about those transfusion thresholds and the clinical recommendations from TAXI. So TAXI was born and through BloodNet, and it aimed to create evidence-based, and when evidence is lacking, expert-based consensus on patient blood management strategies for clinicians caring for critically ill children to maintain a physiologically relevant hemoglobin concentration, optimize hemostasis, and minimize blood loss. And the first series was looking specifically at red blood cell transfusion. And as we know, Marianne Nellis led the second series looking at Taxi Cab, looking at platelet and plasma and creating platelet and plasma guidelines. And so this first series is a 3-part consensus series involved in international multidisciplinary experts on red cell transfusion. It was important to have all of those disciplines at the table when creating these recommendations, so including critical care, cardiology, transfusion medicine, hematology, oncology, surgery, and anesthesia, as well as to engage experts on guideline development and implementation science, because even if we develop these recommendations, we want to make sure that they are implementable at the bedside, and which is the most important part. And so how do we translate what we believe are the recommendations for red cell transfusion, what the evidence tells us, so that our clinicians can use it? And it was modeled after the original Pediatric Acute Lung Injury Consensus Conference called PLEAC. I just wanted to give thanks to those who, to our funding sources, and huge amount of support. So BloodNet served as the executive board for Taxi, and huge support from BloodNet to be able to conduct Taxi. These are our experts, and so by disciplines, and just a quick picture of, and many of them are on the call today as well, so thank you. And this is representation of where they're from. So looking at just a quick overview of the process, and then we'll get into the recommendations. In order to conduct this, we really wanted to be thoughtful about how to create thoughtful evidence-based recommendations for transfusion. Initially started in 2014, we really defined that organizing committee, which was the BloodNet Executive Committee, really defined our methodology, our topics, our experts, to finalize the methodology, analyze the literature, so an exhaustive literature search, conduct the recommendations, and then have a very extensive process of discussing those recommendations using the Delphi method, scoring the recommendations, rewording them if necessary, and then coming up with that final list of recommendations. And again, if they're evidence-based, it was pediatric evidence. If there was only adult evidence, then it was we would have expert consensus, and that will be clear a little bit when I show you the recommendations. And so in terms of methodology, the clinical practice guidelines are statements that include recommendations intended to optimize care, informed by systematic review of evidence. And so Mela Bembia from Johns Hopkins helped us to ensure that our methodology was stringent. And then thanks to Kate Stefan and colleagues from WashU, and now she's at Stanford, to really think about how to implement. And so using implementation science, there are criteria called EGLIA, so guideline implementability appraisal, and you can rate all of these recommendations based on this criteria to really figure out how well the recommendation is going to be able to be implemented at the bedside. And so that was very important as we were starting the process and all the way through. And then looking at Taxi, the subtopics that we looked at, indications of red cell transfusion. So first really taking a big step back and thinking about hemoglobin and physiologic thresholds, and then diving into the populations. And so the populations we looked at were acute brain injury, congenital cardiac disease, sickle cell oncologic disease, respiratory failure, shock, life-threatening and non-life-threatening bleeding, extracorporeal support, dialysis, ventricular cyst devices, as well as alternate processing of blood products. And there were experts, anywhere from 3 to 5 experts in each of those subgroups. So the Taxi recommendations were published in 2018 in Pediatric Critical Care Medicine. We were able to formulate 56 clinical recommendations and 45 research recommendations. And again, when there was evidence, we used GRADE to grade that evidence. And so looking at this in terms of the pediatric evidence, and just to get a sense, we looked at about 55,000 abstracts, and about 120 were included in the end. And so looking at 7% of our recommendations, so 4 were strong recommendations with moderate quality pediatric evidence, 9% or 5 were strong recommendations with low quality pediatric evidence, 20% were weak recommendations with low quality pediatric evidence, so 11 of those, and 36 were consensus panel expertise, which means when there was not evidence, the expert panel came together to create a recommendation. So we're going to dive into this, and this is what I'm most proud of, thanks to Kate Stefan and all of Taxi, who really spend a lot of time being very thoughtful about how to put this into a one-page decision tree. So you can walk through your patient at the bedside, walk through this decision tree to be able to determine what the Taxi experts TAXI experts would recommend. In this decision tree, you also have hemoglobin thresholds, definitions. So again, that hemodynamically stable, it's important to remember back to that earlier slide that refers to how that was defined by Jacques Lacroix's study, and it's below as well in the footnotes. And then looking at the evidence. And so the evidence is here as well. So a clinician can look at the recommendation and then look at where the evidence comes from, how strong the evidence is. And then each of these subgroups had a long text, which really dove into where the recommendation came from, where the evidence was, and why the experts thought and discuss that recommendation. So I'll dive into each of these subparts. So first, just to take a little bit step back before even thinking about this, we did have good practice statements. And so these good practice statements really are from our experts thinking about a globally how we think about transfusion. And so when deciding to transfuse an individually critically ill patient, it's good practice to consider not only the hemoglobin concentration, but the overall clinical context. And the risk, benefits, and alternatives to transfusion, and then to investigate and treat preoperative anemia and to adopt blood-sparing conservation as able. And so when we look back at this decision tree, we're going to dive into each piece. So you have a critically ill or a child at risk for critical illness. And thinking about this, if a child has hemorrhagic shock, our recommendation is we suggest to transfuse. And the suggestion is red cells, plasma, and platelets be transfused empirically in ratios between 2 to 1 to 1 to 1 to 1 to 1 until the bleeding is no longer life-threatening. And this, again, is consensus panel expertise. Now, if you have a child who is not in hemorrhagic shock and your hemoglobin is less than 5, it's recommended to give a transfusion in critically ill children as well. So this is a strong recommendation. It does come from low quality pediatric evidence. There are studies in Africa looking at hemoglobin thresholds, especially those in respiratory failure with the increasing mortality with the hemoglobin less than 5. Between 5 and 7, we don't know, so there's insufficient evidence to make a recommendation. However, it's reasonable to consider transfusion based on clinical judgment. So important to consider this as consensus panel expertise, but we don't know. Now, when our hemoglobin is over 7 and you're not hemodynamically stable, so you're hemodynamically unstable, again, we don't know the optimal transfusion strategy because we don't have evidence in this population. Again, to use best clinical context and ongoing studies are looking at these particular hemoglobin less than 7 as well as hemoglobin thresholds in hemodynamically unstable patients. But those who are hemodynamically stable, we do have evidence for. And so in critically ill children and those at risk for critical illness, if your hemoglobin is greater than 7, we recommend not administering a red cell transfusion. This is a strong recommendation with moderate quality pediatric evidence coming from Jacques Lacroix's TRIPICU study. So looking at this, we want to really emphasize all those populations that would follow this as well. And so those post-operative patients who have non-hemorrhagic anemia, excluding cardiac surgery and are hemodynamically stable, we also recommend not transfusing these patients. In respiratory failure, so excluding severe pediatric ARDS, again, those patients who do not have severe acute hypoxemia, chronic cyanotic condition, or hemolytic anemia, and are hemodynamically stable, we recommend not transfusing if the hemoglobin is over 7. PLEAC is currently, the Pediatric Acute Lung Injury and Consensus Conference is currently updating their recommendations, and this is again still consistent with the current recommendations that are being proposed in that consensus conference as well. And those who are sepsis and recent septic shock. So remember back in that definition, with hemodynamic stability, so you don't have an increase in pressures over 2 hours, and your immunoarterial pressure is not less than 2 standard deviations below the mean, we recommend not to transfuse if a hemoglobin is greater than 7. So again, a weak recommendation with low quality pediatric evidence and extrapolation from the Jacques Lacroix study and that subpopulation of patients with sepsis and recent septic shock. So what about non-life-threatening bleeding? Again, no transfusion. Now, in critically ill children with acute brain injury, a red cell transfusion could be considered if the hemoglobin concentration falls between 7 to 10. So there was much debate in this particular population. There is not evidence, and there was certainly much debate between experts in the room. And what our consensus landed on was between 7 to 10, because we don't know the risks of transfusion thresholds between that. Oncologic diagnoses or those undergoing hematopoietic stem cell transplant, the recommendation is to, we suggested a hemoglobin concentration between 7 to 8 to be considered a threshold. It's a weak recommendation with low quality pediatric evidence. The reason for 7 to 8 is there are studies both using 7 and 8 separately. And so to be able to be consistent with the literature, the recommendation is to suggest a hemoglobin concentration between 7 to 8. Or 7 or 8. And those with allo or autoimmune hemolytic anemia, we don't know. And again, with severe pediatric ARDS, with severe hypoxemia, we cannot make a recommendation regarding optimal red cell transfusion strategy. So recommendation is to use clinical judgment. And the same with ECMO and VAD. And again, ongoing studies are occurring in these populations, so hopefully we'll have future evidence to be able to delineate hemoglobin thresholds in these populations. So next, to take a step back and think about our acquired and congenital heart disease. So thanks to Jill Shillette and colleagues who have been conducting research in this population, thinking about transfusion thresholds and really kind of pushing where our current practice is and showing evidence for lower transfusion thresholds. And so in these patients, we start off with a hemoglobin that's greater than 7 and hemodynamically stable. So these recommendations do not pertain if you're hemodynamically unstable. So those who are stable, first thinking about uncorrected congenital heart disease. And so the recommendation is to transfuse red cells to maintain hemoglobin 7 to 9, depending on their level of cardiac reserve. And these are based on studies by Jill Gillette and her colleagues. In biventricular repair, the recommendation is to not transfuse if the hemoglobin is greater than 7. So now we think about our stage 1 and stage 2, 3 single ventricle palliation. And in these recommendations, a transfusion is not recommended if the hemoglobin is greater than 9, and there's evidence of adequate oxygenation for the cardiac lesion and normal end organ function. And again, single ventricle with a stage 2 or 3 palliation, no transfusion if the hemoglobin is greater than 9. And then in congenital acquired myocardial dysfunction, as well as pulmonary hypertension, we don't have evidence. And here we want to use clinical judgment because insufficient evidence to support a specific recommendation, but there is also no evidence that transfusion above 10 is beneficial. Thinking about sickle cell disease, this is the one population that is not included in the decision tree, and children with sickle cell disease who are critically ill or those at risk of critical illness, we recommend red cell transfusion to achieve a target hemoglobin of 10. Rather than a hemoglobin as less than 30%, and this is prior to a surgical procedure requiring general anesthesia. And then thinking about those with acute chest syndrome, recommend an exchange transfusion over a simple if the child's condition is deteriorating based on clinical judgment. Otherwise, a simple non-exchange red cell transfusion is recommended. Again, it's low quality pediatric evidence, but a strong recommendation. And then we heard a lot about processing of blood products. So thanks to my colleagues, wonderful presentation. And in the subgroup for TAXI, the recommendations, the use of irradiated cellular blood products for all critically ill children at risk for transfusion-associated graft versus host disease, and recommendation for washing as well. So looking back, I like just being able to walk through my patients when thinking about transfusion, and we were able to put more than 95% of the recommendations embedded into this decision tree to be able to walk through not only hemoglobin thresholds, evidence, and level of evidence as well. So next steps, so thanks to Marianne Nellis, who completed and did an amazing job with Taxi Cab, which was just published. And she developed comprehensive evidence and expert-based consensus statements guiding plasma and platelet transfusion. So this is the second step of Taxi. And she looked at plasma and platelet transfusion thresholds in these populations as well. Dissemination, education, and implementation. Again, Kate Stefan is creating decision support tools, embedding that into the EMR, and evaluating the feasibility, acceptability, and impact on practice, which will be wonderful to be able to see how Taxi is implemented and how we can improve in the next iterations of Taxi transfusion recommendations. So again, just to summarize, blood, as we know, is a precious resource. Can be life-saving, but can also cause significant harm. So really to be thoughtful about using patient blood management strategies, transfusion threshold guidelines, blood conservation, anemia and hemostasis management, and to weigh the risks and benefits alternatives of transfusion with each transfusion. And I will stop there.
Thanks, Stacy. There is one question in the chat, just a clarification about massive transfusion and the 2:1 ratio. And that they've read a higher RBC, they've not read a higher RBC ratio for massive hemorrhage, but have read that higher plasma ratios may be beneficial. Where did the committee get the evidence for a higher RBC ratio?
Yeah, and it's only extrapolated on adult studies, so there is not evidence in pediatrics. So you're absolutely correct, until we have, and so it also was debated. It was within Taxi, but it was extrapolation from the adult studies where and there is not evidence in pediatrics. You're correct.
Thanks. Are there any other questions for clarification? We now have a time for question and answer. I don't know if anyone now has questions. I see. Are there any blood modifications that impact immunization recommendations after cardiopulmonary bypass? Kind of an open question. Would anyone like to take that?
We've actually published, this is Neil Blumberg, we've actually published on the subject, and we've looked at patients who were awaiting cardiac transplant, and the combination of avoiding infusion of ABO mismatched antigen or antibody and leukoreduction reduces alloimmunization to HLA antigens to 0, pretty much, or close to it. And this is also true in patients undergoing stem cell transplant and receiving transfusions for acute leukemia, myelodysplastic syndrome. This is both randomized trial data and our follow-up data, which we just published in June of last year in the New England Journal. And as far as the leukemia data, the transplant data was published some years ago in one of the I believe in one of the HLA journals.
So Neil, this is Cassandra. So I think what you're saying is very interesting. I'm not sure that the exact, I mean, you can extrapolate from the things you just said. I think everybody has to be thinking about the delivery of the product and the cost benefit of doing certain manipulations to the products. And I think that it's really important to remember that, washing, which is one of the things we can do for some of these things, actually takes quite a bit of time, and not all blood banks are capable of doing that. And so, especially if you're trying to wash platelets, which have a lot of plasma, and you lose platelets, you also upset the platelets. And so, and you have to let them rest. It could take 2-3 hours. So I just think when people are thinking about transfusing patients and using different strategies, I think we want it to be evidence-based and driven by, what we're finding in the literature, what we can apply. But I also think we have to be practical. And that's why this constant back and forth with the blood bank medical directors and what can and cannot be done for the patients always needs to be kept in mind.
Well, of course, I'm a blood bank director. I don't actually treat patients directly. So, I certainly understand those issues, and they're quite real. I was just responding to the issue about immunization to HLA antigens. I presume that's what was being asked about cardiopulmonary bypass, and washing does not actually improve the results of alloimmunization in our hands. When we did that randomized trial, there was no alloimmunization in either arm of the study because both arms had ABO identical platelets. There was just a difference in survival that was about twofold. I think washing is difficult because we're still using equipment that was developed in the 1970s. We now have a half-hour rest period after washing before infusion because we're using platelet additive solution instead of saline. Platelets, it turns out, don't really like normal saline. It's not very normal. We only use wash transfusions selectively in younger patients with acute leukemia and a few other indications that were actually covered. But I think there's a lot of toxicity from supernatant, and we'll see that more and more as studies are done. But I think blood banks and blood bankers have wildly underestimated the toxicity of giving ABO mismatched soluble antigen and antibody. And I think ABO mismatched platelet transfusions probably do not provide any hemostasis whatever in many settings. So the notion that we're using this because we have to, it's the only thing we have, well, nothing would be better, or tranexamic acid might be better. And we're going to have to start believing the data instead of the dogma.
Yeah, I agree with you. And I just wanted to make sure that the audience kind of took away, because some of people are blood bankers, but most people are not, the intensiveness. And I think that, Cyril and Dolores tried to emphasize, the points of what you can do in the blood bank. And I think that some of the science is pointing towards what you're saying, Neil, so no disputing that. The question is, how do we meet those needs? And I think that's where some of the research, the discussions need to sort of be in the pragmatic, practical. How do we serve the patients once we find what we find? Because I think that we're going to be able to find a lot more interesting information, and we're going to need to be more agile in the blood bank as maybe different inventories, with whole blood, but just what we can do for those products that we've now done more things to, pathogen inactivation, everything, all the different things we've done to the products.
And so there's another question somewhat related in that in the era of universal leukoreduction, what are the rates of alloimmunization after cardiopulmonary bypass?
I don't know that we know that. There needs to be a study there. That's a great question. I think people are very concerned about it and actually limit blood transfusion for certain patients who may need transfusion because they're worried about that, or they're worried about it prior to an organ going in. There's quite a bit of that worry. I can tell you from our study of the, leukoreduction study, looking at CMV in these babies, there's like no white blood cells left after these, very, very few. Now, I'm not saying they can't immunize a recipient, but we're talking about such small amounts with apheresis platelets being generated. We measured with flow the residual white cell counts of all of the units that were transfused, red cells and platelets. And there was only one leukoreduction failure. And we're talking, we could barely count any cells. So I think that, we're doing our best, which is why some people would say, well, that's why we should wash, to get rid of any possible anything in there to give. But the question is, what are the rates? And we really would need to do a study to understand that.
Okay, great. There's another question from Peter Davis. What is the evidence, or is there evidence on how long blood products can hang or be used once the pack is open? They've always been told that it's infection risk beyond 4 hours, but does anyone transfuse red cells, for example, over more than 4 hours?
Hi, this is Cyril. Yeah, we also use the 4-hour time. And I think that's just sort of something that's by consensus. I think the 4 hours is felt to...
It's a standard. It's a standard. It's,
okay.
It's a rule. Yeah,
so
it's a rule. It's a regulation.
Okay. I mean, certainly if it's like a rare unit, you could have like a medical director make an exception. But that's, yeah.
And same with platelets, you'd have a medical director make an exception, like if it was a 24-hour out date after you wash, I mean, a 4-hour out date after you wash, and 24 is for the red cells. But those are on a case-by-case basis. Those are rare instances, not on a regular
And
basis.
is it primarily the risk of infection that people are
Yes.
concerned about?
Yeah, and this is Dolores. I would say most of our pediatric institutions, when that is of concern, usually we have them reach out to us ahead of time because we can always split those products in a sterile fashion. And then that way you can essentially infuse the same volume over a much longer period of time because they've been sterilely aliquoted.
Can I also add one addition to Dolores's answer to the sickling in the leukoreduced units? So she was absolutely right about the sickle. There is sickling, but it's usually due to a decrease in pH. So it's acidity and going through the filter. And so that's usually what can cause some of that sickling in a sickle trait patient who's giving blood. So donors who have sickle trait can give blood, but sometimes them going through the blood going through the filter causes an increase in acidity, and then a sickling of the blood and a clogging of the filter.
Yeah, thanks, Cassandra. Actually, we had an offline discussion with the person who asked the question.
And, okay. I'm sorry. I couldn't see that.
No, but yeah. That wasn't a point I made. But yeah, I mean, a lot of times it's about the electrostatic charge, and yeah, so temperature, pH, all those can affect the filter.
Stacy, I have a question for you if you are available, and to the group as well. But I was wondering with the taxi initiative, if there were any particular research priorities that the group identified moving forward, and maybe how they could even be applied into the REDS database, if at all. I don't know if you're still available though. And that's okay if not, because I have a question for Cassandra as well. And that is, as you describe this, the vein-to-vein database for people outside of the REDS program, will it be open at some point to people outside of the REDS program to investigate?
Yes. So well, first of all, everything's going to become available at the, at the 7-year mark when the program is done in 2026. But questions can come in during the program, especially if you're able to contact people who are involved in the program. And so you don't have to be at a hub to be able to come up with questions. Now, that doesn't mean that the questions are going to get, asked like in a study format, but they may. And, I think we have a process where if you contact one of the people in the hubs, or even people who are consultants for the REDS 4P program, then, we can start a process and we can discuss that at the executive committee level and such to see how we might incorporate some of those questions. So I don't want to discourage people that they have to wait till the end because there are some questions that may be able to be asked. I can't promise that they'll be able to be answered during the REDS 4P program, but you may also be able to turn some of those questions towards the REDS 3 database, depending upon what the question is. And I say that because that data is free to the public and can be looked at. So by any institution, you don't have to use WestStat or any of the investigators that are in REDS 4P or in REDS 3.
Okay, great. Are there other questions from the audience? Okay, I want to respect everyone's time because I know it's been 2 hours. Thank you so much to all of our speakers. Michelle, did you want to add anything else about the CME credit or?
No, just to sign up if you can. And then the recording of this webinar should be available at the bloodnetresearch.org website, aside from proprietary data that belongs to our speakers. So I'll put that together.
Okay, great. Thank you everyone for your time.
Thanks. Bye-bye.
And thanks for hosting, Marianne.